All right, it doesn't look like anybody is showing up tonight, so I will just talk at the camera for a little bit. This week's topic is emergency time management, and obviously this is going to be from an athletic trainer's perspective. So EMS might have a slightly different take or policies, procedures, things that they follow regularly. But for athletic trainers, this should be kind of our bread and butter here in terms of what we are aiming to do, what kind of time responses we need to have for various conditions. So with that being said, the overview for today, there are a list of medical emergencies that we see regularly that are time sensitive, and the most commonly identified are on the screen here. So cardiac events, stroke, severe trauma, uncontrolled bleeding, and severe allergic reaction. So these have been identified in multiple sources as consistent time sensitive medical emergencies, but they were particularly identified by the state of Idaho, who's working to redefine time-sensitive emergencies, and they've actually got a protocol that I've got a link to on the next slide. But one thing that I heard while I was an undergrad, and this quote kind of stuck with me, I don't know if it's 100% accurate. I've had a few discussions with a few different sources that say either yes or no, but it helped me to kind of tunnel vision my thoughts and kind of focus in on what is the priority here. So when you think about death and causes of death, ultimately all of them are stemming from a lack of oxygen to the brain, and they have various pathways to achieve that. But for example, a cardiac event, the heart stops, so there's no circulation being pumped through the body, so therefore no oxygen-rich blood is making its way to the brain, and then ultimately the brain will cause the death of the individual because of the lack of oxygen. So like I said, lots of different ways to get there, but ultimately every cause of death is caused by a lack of oxygen to the brain. So keeping that in mind, kind of going forward of how various causes of death could lead to the lack of oxygen to the brain that would ultimately result in their death. So some of these are going to be more time sensitive than others. Some of these can take quite a while to set in. For example, stroke. There's no real timeline on how fast you need to respond to a stroke, because some set in gradually and some set on a lot quicker. So whereas a cardiac event is pretty predictable. If your heart stops, it's no longer getting circulation, and we know that the brain can only last somewhere in the range of probably 5 to 15 minutes without oxygen. So choking would be another one that's fairly predictable. If somebody's choking and not getting new oxygen into the body, that individual probably has somewhere in the 5 to 15 minute window, and same thing with drowning. But not a lot of ATs are going to see those in their practice. So these are things that the EMS responds to regularly, and they show up in the emergency department. So these are kind of the priority for, like I said, the state of Idaho is prioritizing which medical emergencies need to be trained for. That being said, the three that are the most common, and these are trained within a lot of medical schools as well, the cardiac events, we know that their chance of survival drops somewhere in the range of 7 to 10%. So I just round up and I call it 10% every minute. So if you don't get to them, if you don't get the CPR started, and if you don't get the pads on them to shock with the AED, you know that they probably only got about 10 minutes before they would be proclaimed dead. Whereas with stroke, like I said earlier, the time frame is somewhere in the range of 0 to 3 hours, and that depends on how rapid the symptom progression is. So the typical recognition for those is defined by the acronym FAST. So face, arms, slurred speech, and then time to call. So that's kind of the protocol for recognizing stroke. You're looking at the face. Are they symmetrical? Is one side drooping? Is the smile asymmetrical? Is one side of their face smiling, the other is neutral? And then the slurred speech is another common symptom there. So if you see those things, and if you suspect somebody of having a stroke, you need to get them obviously to the emergency room as soon as possible. That would be responded by EMS. Again, typically ATs are not going to see this, but good to know and good signs to recognize just in case you ever do, and to recognize that even though the symptom progression can take a little bit of time, if you see those symptoms, you want to get somebody to the emergency room as soon as possible so they can get them the medication that they need. Severe trauma, this is again not that likely to be seen by ATs, but it could be depending on the sport. So hemorrhaging, especially if they've got some kind of let's say internal organ damage or rib fractures, things like that. You could have potentially a collapsed airway, a pneumothorax, things like that are going to lead to rapid causes of death, and you would need to get somebody to the hospital as soon as possible with those different causes of death. So if they've got hemorrhaging, again, this is similar to stroke. Hemorrhaging could be various rates. So if they've got a slow bleed that's still hemorrhaging, they're going to die eventually if they don't get care. But if they've got a large bleed, then obviously they're going to have a lot faster decline, and you need to get them care a lot faster. So depending on the size of the bleed, they would have more or less time. That's why it's hard to find the similar timeline that we have with cardiac. Cardiac is a lot more predictable in terms of the drop to the death time. Uncontrolled bleeding, again, same thing as the hemorrhaging, depends on the size of the bleed. But if somebody's got for example, a femoral artery bleed, that's going to be a lot of blood loss very quickly. There was the case, I don't know how many years ago now, but there was the hockey goalie that passed away because the attacking player got checked and lost his balance, and then his skate came up and hit the carotid artery. So then that caused a very quick death for that individual. A lot of blood loss really quickly. So if you can't get the blood loss under control, then that individual is likely to pass away very quickly. Versus if they've got some kind of a smaller, maybe a radial artery, then yes, they're still losing blood very quickly, but it's not going to be as fast if it's a more proximal artery like the femoral artery or the carotid artery. So the severe allergic reaction is something that a lot of ATs would face, and this is something that was talked about in the article that we'll talk about later. The severe allergic reaction is typically the emergency aspect of it is going to be, obviously they're going to have irritation, inflammation, but the problem with severe allergic reactions most of the time, it could be shock, but a lot of time it's going to be the closed airway. So if they have a closed airway, they're no longer getting oxygen in, and then it's in that same 5 to 15 minute window where if you don't get that airway opened, then a lot of times that individual is going to pass out, and then they're going to proceed with either cellular damage or potentially death, depending on the timeline there. The legal death is a bit of a tricky subject, and every state defines it a little bit differently. The state of Texas defines it as cardiopulmonary death plus brain death, and so it's necessary for a doctor to describe both. And so they could have, for example, the cardiopulmonary death, which would be like biological death, which would be the ceased spontaneous respiratory or circulatory functions. Whereas their brain could still have normal and healthy electrical activity, and it's still functioning like it should. They would have normal sensations. Well, they're likely unconscious if they have cardiopulmonary death, but their brain would still have electrical activity that would suggest they could be resuscitated. Whereas with brain death, they have that irreversible cessation of spontaneous brain activity, and the I believe it's Stanford, I could be wrong about that, but they defined it as the irreversible coma. And so again, they could be on a respirator or a ventilator, and they could have forced bodily activity, but if their brain is not able to then conduct electrical signal to the heart, to the lungs, to function normally, then as soon as you take them off of that life support, then they're going to pass away. So that's the difference there in terms of biological death or brain death. But depending on the state you live in, that pronunciation of death could be a little bit different. So again, why is this important for ATs? In terms of our biggest priority is the health and safety of the athletes that we work with, and the biggest, most urgent situations that we're going to face could be life and death. So knowing about how much time you have to respond to these various conditions, and also what kinds of care you need to get. So for example, if you know you have an athlete with allergies? Do you have an EpiPen with you at all times? Do they have one with them at all times? With travel, a lot of teams they'll bring an EpiPen in their, for example, their medical kit, but then they're going to check their medical kit underneath the plane. So if you can't access it, then it's no good. So being aware of those kind of things, trying to prevent as many of these preventable deaths as possible, but then also knowing how to respond to the things like the cardiac, the stroke, the trauma, depending on which sport you work with. If you're hockey, obviously there's a big risk there. And we talked about the different sport risks for significant bony fractures last week. But the other thing that I thought was kind of funny was if you start Googling and you're trying to research and read up on a lot of causes of death and timelines of death, apparently Google flags that. They don't like that. They told me that help is available and that I should speak with someone today. So good for them. It's something I didn't foresee as I was researching this process, but I suppose when you're Googling what's the fastest way to die, they probably think something might be wrong there. So good on Google to reach out and try to help prevent some of these deaths as well. So for the literature review, I hinted at the Idaho TSE system earlier, and that's on their website. So this link is in the literature review if anybody wants to go back and review it on the website. And then they give guidelines for recognition and care of all of the time-sensitive emergencies that were listed earlier. So how to recognize a cardiac event, how to recognize a stroke, how to recognize trauma, and then what to do when you see them. Should you stabilize the individual? Should you start CPR? Should you get the AED? All of that stuff is on there. And some of it's going to be basic care for ATs. It's pretty simple stuff that we all know and practice. But some of it's a bit nuanced. And again, from the perspective of an EMS, where they have a little bit more training, especially with that transport aspect, or the arrival to the hospital, then it could give some interesting insight if anybody's curious about that. The last three links at the bottom are the timelines. And so the state of Florida conducted a study for the time that it took the EMS to respond to stroke victims, how long it took them to drive and get there, how long did it take them to provide care, and then how long did it take them to get them back to the emergency room to provide further care once they were in the hospital. The second study is the time to care for the heart attacks, and then the survival rates accordingly. So if they get a rapid AED, rapid CPR, and then an AED, their time or their survival rates go way up. If the time to care drags on, then that survival rate decreases. So then the last one is trauma, and then the survival rates based on treatment time. And this one I thought was kind of interesting because it was there were a few variables there, not only just how long it took the EMS to get there, but how long they were actually providing treatment on scene versus getting them in the ambulance and taking them straight to the hospital. So some interesting implications there. But if anybody wants to read about trauma timelines, then that's a good link for you. So the study for this week, it was very hard to find a paper discussing scientific literature discussing emergency time management. And so I did the best that I could with the collaboration between EMS and certified athletic trainers. But some of it won't be necessarily time related. It's just talking about emergency responses and the preparedness for ATs. So kind of keep that in mind, that it won't be as specific as some of our previous topics have been, but the paper should still be interesting in terms of the AT's ability to handle various emergencies. So what the study design was, they took 64 EMS directors and 224 ATs, and they conducted 2 different surveys with each of them. Basically it was assessing the confidence in the AT's ability to handle various emergencies. So I thought this was a weird design study, but this was published back in 2005, so it could have been improved upon since then. But the EMS director group and the AT group got 2 different surveys, so it wasn't as if all of the questions on there were identical. There were slightly different emergency cases for ATs and the EMS directors. So not sure why that was, but there was a significant amount of overlap. The EMS directors, I think, had 11 items that were similar as for ATs. That would include things like dislocations, AED applications, spine board, those things. So the overlap is really what this study was interested in, and what the perspectives were from EMS directors and from ATs. What they found as a whole, we'll go into the details in a second, but as a whole, what they found was that ATs' confidence increased with practice and experience, whereas EMS directors' confidence increased in ATs if they were having regular meetings. Particularly in this, they asked about preseason meetings. So if the EMS directors met with the ATs before the season, their confidence in the ATs' ability to handle those emergencies went way up. So we touched on this with EAP planning in one of the previous lectures, but again, a good take home, a good practice for all ATs. Meet your local ambulance, practice with them if you can, get to know them, ask about the handoff, ask about the transportation, and really smooth out that process as much as you can before you're in an emergency situation. The more you can practice and prepare with the EMS, the more confident they are with you, the more confident and familiar you are with them. So meeting with them, practicing with them, all of that will help smooth out that process and hopefully increase the survival rate of the athletes. The paper really harped on the perceptions of ATs, and they talked about how a lot of the perceptions and respect for ATs lagged the education and training that they received. So they talked about the NATA's domains and how emergency care was one of them, and emphasized in all CADI accredited programs was the practice of AEDs and emergency preparedness. So that's all pretty standard practice now, but again, this was 20 years ago, so it's a little bit outdated. And I think that the education and clinical training for athletic trainers is only improved since then. So I'm obviously biased, but I think every AT student in the country would tell you they're getting some kind of emergency preparedness in their clinical education. So that should change now. The kind of zooming in onto the ATC confidence, it increased with more emergency experience. And so what a lot of young clinicians face is that they've never had to respond to an emergency in their undergrad or grad school training. They might have clinical experience, they might see various emergencies happening, but they themselves are not the ones responding. They're not stabilizing in a C-spine emergency, for example. They're not the ones that's applying the pads from an AED if it's a cardiac condition. Usually it's the preceptor, the certified athletic trainer, not the student. So a lot of athletic training students graduate without that experience, or even fracture care. It's all simulated because they never got a chance to actually apply that clinical education. So they graduate with this kind of uncertainty of what happens if I do this. Like, I know what I'm supposed to do, but I've never seen it before, so I don't know how I'm going to respond. And to this, I would respond again. I think that the military slogan of you tend to fall to the level of your training, not rise to the level of the occasion. So I think that a lot of ATs need a lot more practice on this. I think EAPs need a lot more consistent review. I think it's common and it's required in a lot of instances for, I believe it's annual training and preparation of the EAP, but I think even more than that is helpful. I think if you can do it once a month, that's even better. And really just trying to, even within your own practice, try to poke holes in your own plan. Like, okay, well, what if this athlete collapses? We talked about an unconscious athlete last week who had run into a wall and weren't able to C-spine because they were up against a wall with a single clinician. So practice those kinds of things. If you have one AT, what happens if this happens? What happens if that happens? If you've got a team of medical staff, including EMS on standby, well, what happens if they're in this location versus that location? What happens if it's the AT who goes down with some kind of a cardiac event? So then who's responsible? Like I said, poke as many holes in your plan as you can, and then that'll only make your process that much more effective. with the along with the emergency experience, and that goes hand in hand with confidence, is the advanced certification. So they talked about AED certifications. Again, I think this is pretty standard for any, I think it's required for any employer to have certified athletic trainers be trained and certified for AED application. The one that I found interesting was EMT B and P certifications. And so these are different qualifications based on the emergency technicians. You can either have a basic certification or you can have a pararescue or, oh, no, I'm drawing a blank on the title for it, but the EMTP is the more advanced certification. And so for the certifications there, it's interesting. They talk about ATs would be a lot better prepared if they would even just take the EMTB course. And if they do some ride-alongs, for example, with or some volunteering work with the EMS. It's something that I'm interested in, and I think that would benefit anybody who wants emergency exposure. I think you're going to see, I mean, I've had friends that work with EMS or with emergency rooms before, and the likelihood that an AT sees a cardiac event in their career, maybe one time, two if they're extremely unlucky. But these doctors and EMS staff in the ER, I mean, they're seeing probably 8 to 10 a day. So the amount of reps they're getting in these emergency situations is just, it prepares them that much more. And I think that you get over that kind of fear of uncertainty the more you do something. So something that I'm going to look to do in the future would be that EMTB certification. But I'd be curious to know if any other ATs have that, if they found it valuable, or if they went even further and got that EMTP certification. The emergency situation, the cases that ATs were most confident in, they had high confidence in splinting, dislocations, lacerations, concussions, the things that we see regularly. And this again goes to the discussion point of the paper. The things that ATs don't see very regularly, the AED application, the diabetic emergencies, the respiratory emergencies, those things that ATs don't see very often are the things that they lack confidence in, which it makes sense, right? The less you do something, the less certain you are that you could do it again. So try to get experience, try to get exposure in these emergency scenarios, practice your EAPs, and try to poke holes in your EAP so that you can make it even better. The perspectives here, I think that this was an interesting slide or an interesting figure in the paper. The comparison of AT's confidence versus EMS director's confidence for the various conditions that overlap. So at the top there, you can see the least amount of confidence. It's consistent across both groups, but the level of confidence decreases for EMS directors. So ATs always thought they were more prepared than what the EMS directors thought they could handle. And there's some different arguments within the paper as to why this might be. So maybe it's the ATs that are overestimating their abilities, or maybe it's the EMS that are underestimating the abilities of the ATs. And to that point, it would make sense, because if you had a preseason meeting with the EMS staff, then their confidence in you goes up. So maybe it's just the EMS lack of awareness of ATs, or misunderstanding of the roles and responsibilities and the clinical education that ATs get. And again, this is from a 2005 publication, so things could have changed, and especially the ATs within the last, I would say, 3 or 4 years are getting a lot more media coverage. So now that they're getting that exposure, people are starting to recognize the importance of athletic trainers in emergency responses. Damar Hamlin pretty much broke mainstream news for any news channel. ESPN, obviously, it was all over that for breaking news. So the athletic training staff there was acknowledged in the SB Awards. They were all over the news. They had a ton of recognition there. So I think ATs get a lot more respect now than they did in 2005, but I would still guess that these charts would align somewhat similarly, to the point where I think diabetic emergency, use of AED, and respiratory emergencies are all going to be lower confidence items for ATs. And then I think also ATs are going to have more confidence in themselves than EMS would in them. So to wrap up, again, all causes of death are ultimately caused by a lack of oxygen to the brain, and there are various timelines caused by the different medical emergencies that are time sensitive, and these different causes of lack of oxygen to the brain have implications for how much time you have to respond to these different things. So if you see a cardiac collapse, making sure that you're getting CPR and AED applied as soon as possible, recognizing that if you're taking your time to get out there and check on them, and then you walk back to get the AED, and then you walk back out to put it on, recognizing that you're losing precious time there. So the cardiac is extremely emergent. Obviously, choking or respiratory distress, those kinds of things. Severe allergic reaction could be as well. Any kind of an oxygen related issue, you're going to have somewhere in that 5 to 15 minute window to get them the appropriate care. Stroke has different implications depending on the symptom presentation, but for the most part, you have somewhere in that 0 to 3 hours to get them the appropriate medication. And the sooner you can get it, the better. I saw a quote on this. I didn't think it was medically backed, but it was an interesting talking point, and it probably has some relevance or accuracy. And it said for every 15 minutes, I believe it was, of unmanaged stroke victims, it was taking 36 years off of the age of their, or adding 36 years of age to their brain. So the amount of damage that is caused by lack of oxygen to the brain definitely plays an impact in brain health. Severe trauma, again, another one that's going to take a rapid response, especially if it's involving some kind of big hemorrhage or internal organ disruption, laceration, something along those lines, or a collapsed lung, some kind of an airway that's unstable. So that should wrap it up for this week. And then starting in the month of February, it'll all be strength and conditioning focused. And the first week's topic will be dosages. So talking about how to program different amounts of strength and conditioning, especially what's relevant for athletic trainers is going to be that kind of reconditioning phase. So making sure that you're getting the appropriate times for running, the appropriate amount of sets and reps, the appropriate amount of weights, that kind of stuff. So prescribing the appropriate amount of dosages for whatever the given injury is and where they are in that timeline. So that'll be covered next week.